같이 갈 곳이 있어서 그랬어. 한국말을 모르겠어. 가요.
the speaker. Not busy. He didn't rejoin the meeting.
Hello guys, good morning.
Morning. Oh.
Yes, and please Doc could be joining us very soon. We're having some technical difficulty, which hopefully we have resolved. So he'll be joining us very soon. I apologize for that. Thank you.
Hello? Hello?
Hi.
Doc.
Right, so sorry for the delay. Do we have any questions from what we did last week? Peptic ulcer disease. Any questions, any concerns, any contributions that we may add to what we did? If not, we are doing GERD today. It's almost similar to PUD, but this time it's happening within the esophagus, not the stomach nor the duodenum. I expect that we will finish earlier than our concerns. Class captain, anything that you have before we start?
No, please.
Okay. All right. So today's topic will be gastroesophageal reflux disease. Excuse me. All right. So let's do a little bit of introduction with terminologies. So all in all, we are talking about gastroesophageal reflux disease. And this basically is all about the stomach and at times the small intestine's content, mainly bowel secretions, moving from the small intestines and the stomach into the esophagus. Of course, these agents that comes there, the fluid that comes there are normally acidic or slightly basic. And the structure of the esophagus is such that it doesn't have enough defense mechanisms to contain this. And therefore, burning sensation. That he or she may describe, probably the heart is almost around. It doesn't actually have a direct link with the heart. yet we describe it as heartburn. Proper heart issue will be coronary artery disease, for example, pain from angina. But this time we are talking specifically about the esophagus. Movement of fluids from the small intestines, stomach, into the esophagus, where we experience some burning sensation. Now, in most cases, when the acid moves from the stomach, as an example, into the esophagus, the acid will lead to an inflammation. So if the refluxate, if I say the refluxate, I'm talking about the fluid that is regurgitated. If it comes into contact with the esophageal lining and it's resulting esophageal inflammation, then you will term it as reflux esophagitis. Only inflammation, there is no injury yet. You refer to it as reflux esophagitis. You have the acid, the hydrogen ions coming into direct contact with the lining of the esophagus. Esophagus is lined with squamous epithelial cells. Squamous epithelial cells is what naturally lines esophagus. So when this becomes inflamed, reflux esophagitis. At times, you have more. It will be more severe than the mere inflammation, and there could be erosion of the epithelium. In that case, you refer to it as erosive esophagitis. So when you have only the inflammation from the reflux, it is reflux esophagitis. In addition to the inflammation, if you get erosion, damage to the lining, then you refer to it as. In most cases, the signs and symptoms that people will suffer will purely be based or come from only the esophagus. At times, people also experience signs and symptoms that are not related to the problem within the esophagus, which means that the refluxate has even moved past the esophagus to other areas like your pharynx, your larynx, your lungs. Even it may come into your mouth. And people will begin to suffer from symptoms that are related to these areas. So, for example, through the airways, the person may cough, the person may have laryngeal inflammation or pharyngeal inflammation. At times, repeated exposure of your even teeth to the refluxate can even lead to erosion of your teeth. These signs and symptoms that are extra to the esophagus, when it happens as a result of reflux disease, then it will be termed as atypical or extra esophageal reflux disease, gastroesophageal reflux disease. So if you have extra esophageal signs and symptoms, not the typical heartburn, but maybe the refluxate enters the airways, that will trigger some cough, your larynx or pharynx becomes inflamed, your teeth, there is a problem, all because of some reflux, then you term it as atypical or extra esophageal GERD. At times, people will get the normal heartburn, but when you do endoscopy, you realize that there is no problem within the esophagus. Not any erosion, you won't find any distractions there. The esophageal lining is intact, but the person is presenting with typical signs and symptoms of GERD. In that case, you term it as either symptomatic or non-erosive. Non-erosive because there is no erosion. The lining is intact. Or endoscopic negative. On endoscopy, you are not seeing any damage. So it is negative. So you can term it like any of these three. Symptomatic, there are symptoms, fine, but you don't have any erosion, and the endoscopy, there is nothing wrong within the esophagus. Then you term it as endoscopic negative reflux disease or non-erosive reflux disease or symptomatic GERD. When you get repeated exposure, biliary secretions, pancreatic secretions, stomach secretions, these are harmful agents and may lead to complications. One of them could be strictures, especially if the pH is too low, highly acidic. It can even burn the esophagus as if the person has taken maybe some artificial acid, maybe conc H2SO4 or conc HCl. It can even melt the esophagus, and then the two sides may stick together to the extent that there may not be any passage through the esophagus. When this happens, then we say that you have esophageal strictures. You melt, then the person will have this complication. At times too, when you have exposure of the squamous epithelium, and the squamous epithelium, it is eroded. And unfortunately, when you are having growth, you don't get squamous epithelium again, but you get columnar cells replacing the squamous epithelium. In this situation, you refer to it as Barrett's esophagus. So erosion of the original squamous epithelium, and then when it is replaced by columnar epithelium, then that esophagus will be referred to as Barrett's esophagus. Unfortunately, if you get Barrett's esophagus, it predisposes that individual to cancer. So you get replacement of the squamous epithelium with columnar, and that may lead to cancer. Of course, when you get erosion and it affects blood vessels, the person may also bleed. That could lead to anemia. So these are some of the common complications that may happen when somebody gets GERD. And depending on the severity, any of these can happen all the way to the extent of even cancer. Any question, any confusion here before we proceed?
Sir, I missed the part where you explained the strictures. Can you please take it again?
Yeah, so the strictures is just like, for example, when a small boy or small girl swallows a caustic agent, maybe a very strong acid or base, then it can burn the esophagus and melt the esophagus. But during healing, you realize that it can even stick together, such that the lumen is lost. You may have to do surgery to open it again. So that is what we refer to as esophageal strictures. If the refluxate is highly acidic, then it can also burn the esophagus and cause sticking of the two sides together, and the only intervention will be surgery. Are you okay?
Yes, sir. Thank you.
Any other concerns? All right. Now, this is just trying to depict the upper GIT, where you have the esophagus, the blue lines depicting the diaphragm. Just below the diaphragm, between the esophagus and the stomach, will be a very important anatomical structure called the lower esophageal sphincter. This sphincter is like a valve, a gateway that controls the movement of substances that you swallow into the stomach. It opens when there is an incoming object, so that that object can enter the stomach. And under normal circumstances, this structure is always contracting to keep the junction closed. It only opens when there is an incoming object. It's always tonic contracting simply because when it relaxes with the abdominal pressure, the stomach content can move up into the esophagus and GERD may occur. So constant contractile effect, constant tonic state of the LOS is very important in preventing the movement of substances from the stomach or the duodenum back into the esophagus to cause GERD. When the LOS relaxes, we are in trouble. So it controls the movement of substances into and out from the stomach. Very, very important. Then, as you know from last week, this is the body of the stomach. The fundus is up here, the antrum, the pylorus, then you enter the duodenum. Interestingly, you can have substances or fluids all the way from the small intestines moving back through the stomach to join the stomach content and then causing reflux. If this happens, it is referred to as alkaline GERD. So alkaline GERD is not actually that basic. It may even be slightly basic or still acidic because of bile acids. But to differentiate it from the normal GERD caused by the stomach content, about 10% to 20% of the world's population, people always suffering from GERD. It's just a common thing that normally happens. But in the Western countries, it is more common than over here. But now that we are changing our diet and our lifestyle and behaving as if we are white, for now, if new epidemiological studies are done, I will not be surprised to see that now we are even almost the same as the Western world, eating a lot of fats and what have you, a lot of drinks, caffeinated products and what have you. So we may be approaching the level at which they also suffer. In terms of sex, whether you're a male or female, the disease doesn't differentiate a lot, except during pregnancy, and the non-erosive GERD that is more common in females. Obviously, during pregnancy, your risk factors increases. The developing fetus enlarges the uterus, which will bring in pressure in the abdomen. So that pressure will press on the stomach and the pressure will fall on the LOS and may give the movement of the stomach in the LOS. In addition to the increasing abdominal pressure, the hormones that will keep the pregnancy, that is progesterone, estrogen, these hormones can cause the relaxation of the LOS, the lower esophageal sphincter. Remember, it must keep itself tight to prevent the movement of substances from the stomach into the esophagus. But in the presence of high amount of progesterone and estrogen, for example, during pregnancy, these hormones will cause relaxation of the LOS. So the LOS is open, you are having abdominal pressure. Simple. The refluxates will move and it will have contact with the esophagus. Again, this agent can also minimize gastric emptying. So the rate at which substances leave the stomach and move into the small intestines may reduce. By so doing, you increase the competency of the LOS, moving the stomach content up into the esophagus for GERD to happen. Other than that, in general, you don't have so much difference when it comes to males and females. But during pregnancy, that normally happens a lot in females. So pregnancy is a high risk factor when it comes to males. But in general, in your family, if there is this history of GERD, you may inherit it. If you are obese, you tend to have a lot of pressure within the abdomen, fat and all those things, big tissues, organs being enlarged, putting pressure on the stomach. So obesity can result in GERD. Smoking, nicotine can also relax the LOS. If you smoke, the active ingredient is nicotine. So nicotine can also relax the lower esophageal sphincter. And of course, once it relaxes, it opens. Stomach content can easily pass through. Nicotine also decreases gastric emptying, just like progesterone and estrogen. And therefore, it may contribute to increased intragastric pressure. Alcohol will do same. It can relax the LOS, and therefore, it keeps it open. Several other medications that we are going to look at very soon, calcium channel blockers, theophylline, and what have you, all these agents can relax the LOS or can even cause irritation of the esophagus and contribute to GERD. If you already have respiratory diseases like asthma and what have you, that may also put you at risk of extra esophageal GERD. The slightest movement of the refluxate into the airways, then the extra esophageal GERD may happen. Pregnancy, we've spoken about pregnancy, estrogen, progesterone, reducing LOS sphincter pressure, decreasing gastric emptying, developing fetus, increasing abdominal pressure, and then in combination, these factors may contribute to GERD. Any question? Any question so far? Any question? Class captain?
Hello.
Yeah, hello?
Yeah, please, sorry to take us back. Could you please go back to the previous slide, which had the diagram? Yeah, you mentioned something about alkaline GERD, so I was wondering if you could repeat what you said. I didn't hear it.
So if you have secretions that comes from the small intestines causing GERD, to differentiate it from the one that comes from the stomach, then we refer to it as alkaline GERD. Though the refluxate or the fluid that will come there may even be slightly acidic or slightly alkaline. So it's not actually like alkaline in nature, but it's a misnomer. It's a misnomer because it's not actually like a strong alkaline agent that is coming. Because you may have bile acid that is coming, pancreatic secretions and what have you. This may even be acidic, but to differentiate that one from the cause from the stomach itself, they refer to that one as alkaline GERD. Are you okay?
Yes,
So
please, thank you.
when you hear alkaline GERD, it does not necessarily mean that it is an alkaline refluxate or the solution or the liquid that is coming is highly alkaline that is coming to cause the problem. But it's a means to differentiate it from when the cause is directly from the stomach fluids. All right. So now let's look closely at some of the food substances and drugs that can contribute to GERD. So we have those that decreases lower esophageal sphincter pressure and keeps it relaxed and open. So food substances like fatty meal. So you realize that when you eat at night and it contains a lot of fat, in most cases, you may suffer from heartburn because the fat in the meal will relax the LOS and will even increase your intragastric pressure. So it will load up pressure within your belly whilst relaxing the LOS. These two combined regurgitation will occur. Garlic, carminatives like peppermint, spearmint, onion, which is almost in the same group as garlic. Take a lot of chocolate, coffee, cola, tea, pepper. All of these can relax the LOS. Drugs that we are supposed to note include anticholinergics, alcohol, barbiturates, cigarette smoking, caffeine, your nitrates, dihydropyridine, calcium channel blockers, progesterone, estrogen, and obviously the natural one increases during pregnancy. So the synthetic ones will also do same. Theophylline, dopamine, tetracycline. All of these agents can reduce the LOX pressure and keep it opening. So if you have your patient on any of these medications and they complain of heartburn, then during your review, you may give considerations to these medicines. Any of them could be the cause of the heartburn. And if it is possible that you can switch to solve the problem for the patient, then you may do so. Then others, food substances, medications that will cause direct irritation to the esophagus and contribute to GERD. So once you take spicy foods, tomato, that I'm always surprised because I expect pepper to be causing irritations, but they say tomato also causes irritation. Orange juice, of course, acidic in a way, so it's not surprising. Then coffee. Drugs that are noted to cause irritation includes alendronic acid, that is used to manage osteoporosis. Our good old iron preparations can cause irritations. Aspirin, acidic, not surprising. Quinidine, NSAIDs, and our good old KCL. All of these may cause irritations to the GIT in general, including the esophagus, and contribute to GERD. If this happens and you're on iron, of course, then maybe taking it after meals will help. Tetracyclines can also cause irritation. And normally it is advised that when you take tetracyclines, within 1 hour, you don't have to lie down. If you lie down within 1 hour after taking any of the tetracyclines, be it oxytetracycline, doxycycline, monocycline, or what have you, from GI irritation. All right. Now, what is the pathophysiology? What actually goes on wrong in the body against physiology that results in GERD? All right. So you have lower esophageal sphincter pressure. We've been talking about it. This is probably the most.
Can you please go back to what you said about the tetracyclines? I did not hear you.
So what kind of counseling do you give when you dispense tetracyclines?
You don't take
You've
it on
dispensed
an
tetracyclines
empty
before?
stomach. Yes, please.
Why?
Yes, please.
Hello?
The product's label says because of GI irritation.
Hello? Your line is not stable. So you don't take it on an empty stomach. Additional counseling point is the patient is not supposed to lie down within an hour after taking it. If you do so, it may contribute to the irritation. This may contribute to GERD. So all tetracyclines, you take them, stay upright at least for an hour. You sit or you stand or you do your normal rounds. don't go and sleep immediately after taking tetracyclines. Don't take it on an empty stomach, sake of irritations. Can you hear me, please?
Yes, please.
All right. So the pathophysiology. So probably the most important factor is the LOS pressure. This LOS, we say that it should always be in a tonic state, always contracting, so that it will be tight, not to allow substances from the stomach or the duodenum to move through and then come into contact with the esophagus. But in most cases, whether in the presence of some hormones, drugs, food substances, or on its own, there may be transient or spontaneous relaxation. And if you are not lucky and at that time you are positioned in a way or you are doing anything that can increase intra-abdominal pressure, then quickly the stomach content can pass through. So even spontaneous transient relaxation is enough to allow substances to move through and come into contact with the esophagus. Of course, if this comes together with increasing intra-abdominal pressure, then you worsen the thing. Or it refuses to contract. You have an atonic LOS. So it is always in a relaxed mode and it is wide open. These three combined can easily give you GERD because the regulator is not working, is not competent enough, and therefore it is going to allow substances to move through from the stomach and the duodenum into the esophagus. You could also have anatomical problems related to the anatomy, the structure that we've looked at so far. For example, hiatal hernia. So normally you will have the lower esophageal sphincter below the diaphragm. So you see this is where you have the diaphragm and the lower esophageal sphincter is here. You can see that it is squeezing very tight and the content here cannot easily pass through and come into contact here. For whatever reason, you may have herniation of the hiatus. So you see that you are not supposed to have part of the stomach passing through the diaphragm. The space within the diaphragm is called the hiatus. You are not supposed to have some part of the stomach passing through and then coming up. But that is the nature of it. But here you can see that some aspect of the stomach has gone past the hiatus and it is now almost up here. And therefore, this can make it very easy for content to move through the herniated stomach easily into the esophagus. So that is one of the anatomical problems that can also contribute. Previously, we thought that that was the main cause and the most important cause of GERD. But nowadays, we are giving all the funds to lower esophageal sphincter pressure. It is the most important parameter when it comes to the contributory factors to the pathophysiology of GERD. Nevertheless, anatomical factors, that is mostly hiatal herniation, also still has a role to play. Not only these two, is the esophagus itself also competent to defend itself should in case maybe the secretions come. The LOS has failed. Hiatal hernia has occurred. Now the secretion is in the esophagus. If the esophagus can't protect and defend itself, it is still not easy for GERD to occur. So yes, the other parameters may fail, but you, the esophagus yourself, can you also defend yourself? So let's look at issues in relation to the esophagus itself. One of them is esophageal clearance. If anything comes into contact with the esophageal lining, can the esophagus remove that thing as quickly as possible so that if that thing is harmful, like acid, it will not have enough contact time to do the damage? Can the esophagus do that on its own? When the LOS fail, when you have herniation, can the esophagus also defend itself? Things that the esophagus may use to defend itself and to decrease contact time with a refluxate may include peristalsis, the normal peristaltic movement, or even with swallowing. The moment you swallow, you see the movement downwards from the esophagus. Of course, can it be able to clear that movement, sweep whatever is in contact with the esophageal lining back into the stomach? Obviously, the esophagus is above the stomach and the duodenum. With gravity, the mere fact that the esophagus is on top, if any liquid is in the esophagus, it's expected that it will drain by gravity into the esophagus. Is that enough to help clear whatever fluid that comes into contact with the esophagus back into the stomach, to minimize contact time and to prevent damage? If you are able to secrete enough saliva, saliva contains bicarbonate, it contains growth factors that even when you have damages within the esophagus, the growth factors can initiate cell growth to help with the healing. The bicarbonate can also help neutralize the acid that comes into contact with the esophageal lining. Are you able to secrete enough saliva to help the esophagus do this? Unfortunately, when you are aging, you tend to have a decreased production of saliva. And for that matter, it's not surprising that in the aged, they frequently report that they are having GERD as compared to their younger age counterparts. If you have xerostomia, or xerostomia normally comes from the side effect of certain drugs, for example, antimuscarinic agents, where it decreases your salivary glands' capacity to secrete enough saliva. Sturgeon's disease is an autoimmune reaction when the salivary glands are affected, and therefore you tend to have reduced production and secretion of saliva. And of course, any of this can contribute to reduce saliva, and the beneficial effect that you get from saliva, the bicarbonate content, the epidermal growth factor content, even the flow that can contribute to gravitational sweeping, you may lose it. Again, you realize that in most cases at night, people do suffer from GERD during nighttime. You eat gobe in the afternoon or evening, nighttime that you are going to bed, then you complain that you are having GERD. This partially can be attributed to the fact that during nighttime when you are sleeping, you don't release a lot of saliva and you don't swallow enough as compared to the daytime when you are active, you are secreting and you are swallowing. And therefore, this in part will explain why people do suffer from GERD at night more than during the daytime. When you are aging, your salivary glands will slow down. You produce lesser amount of saliva, and therefore aging could be a risk factor in this way. Sturgeon's disease, an autoimmune reaction, the salivary glands are affected. Obviously, you are not producing enough. Xerostomia, possibly from the side effect of certain medications, will reduce your saliva production, and that can also affect you. Again, still within the esophagus, the mucus or the mucosal lining of the esophagus, is it resistant enough? If you look at the stomach, you have a lot of mucus production, local bicarbonate production. That in most cases, if you don't engage yourself in a lot of aggressive factors, is enough to prevent ulceration or inflammation. Is the esophagus also prepared in this nature or in this manner to also fight any acid that comes there? Obviously, the esophagus is not structured as the stomach, and therefore it tends to suffer when you have contact. But still, it has its own way, not up to the standard of the stomach, but it still have its own way of defending in a minimal manner. So, of course, you have within the mucosa of the esophageal lining, you produce mucus, not as much as the stomach can do. But at least if it's intact and the mucosal lining is working, you could produce enough that can produce. Again, local bicarbonate production within the cells. If these are functioning very well, it could also contribute to acid neutralization should the acid comes there. So the mucus will form a barrier to protect the esophageal lining from direct contact with the refluxate, whilst the bicarbonate that is produced locally will help in some level of neutralization. Is there enough blood flow? So that even if you have a damage, that you don't get the injury there. This obviously will be affected by the amount of prostaglandins, that you have enough enough blood flow to the esophageal lining, and there will be healing. The epithelial junctions, the squamous epithelial cells, their junctions, are they that tight to prevent inflow of the hydrozonium ions into deeper layers to cause injury? If the junctions are not tight, then easily the hydrozonium ions can enter and cause inflammation. How fast are you able to replace these epithelial cells when they get damaged? So epithelial cell turnover, are you going to meet the task? And of course, the epidermal growth factor that comes from the saliva, do you have it enough, and are the cells able to respond so that they improve the turnover rate? These are all possible defense mechanisms that the esophagus can utilize to defend itself against any harsh refluxate that comes in from the stomach or the duodenum. Then gastric emptying. You have a lot of stuff in your stomach. These things are not leaving the stomach into the small intestines for absorption or through the colon and outside the body. You build up stuff like that, you increase your intra-abdominal pressure. This can even overcome, even if the sphincter is working. If the sphincter is competent and you have extremely high abdominal pressure, it can overcome regurgitation will occur. As we've mentioned earlier, nicotine that you find in cigarettes during smoking can delay gastric emptying. Fats can also delay gastric emptying. In addition, progesterone, estrogen, and the stuff can all delay gastric emptying. And once you delay, everything stays. It increases the gastric volume, it increases the pressure, and this can contribute to GERD. Unfortunately, in infants, some of them, the antral portion, let's go back to the diagram, the antrum, you see here, this part of the stomach becomes atonic, and therefore the content here cannot easily move through the small intestines and then reduce the pressure here. So if you have antral motility problems, this normally is common in infants. Then the infant will suffer from frequent, it doesn't go well with them. Times they fail to thrive with repeated problems. They can even aspirate and get aspiration pneumonia. So this is not well. It's not good for infants when they get antral motility problems. Then the next one is the composition of the fluid itself that is being regurgitated, the acidity, the volume. So if you have even a small volume, but it is highly acidic, then it could be enough to still cause damage, because high acidity will easily damage your cells. It will denature the proteins of the esophagus. Remember, you also have pepsinogen that in the presence of this high acid, it will be activated to pepsin. And therefore, the lining of the esophagus, remember, is also protein. So the activated pepsinogen to pepsin by the very low pH can also cause damage to the esophagus. I just mentioned alkaline esophagitis. That is when you have the secretions from the small intestines, and obviously it will be coming from the bowel and the pancreatic secretion. You have a lot of proteases in the pancreas, trypsin, chymotrypsin. All these, when they form part of the refluxate, can digest the stomach, the esophageal lining. Bowel secretion is acidic and can also contribute to it. So when you have the esophagitis coming from such secretions, to differentiate it from what comes from the stomach, you term it as alkaline esophagitis. I said terming it as alkaline is a misnomer. It's not actually alkaline because bowel secretion is acidic, but it's just a term to differentiate it from what you have in the stomach. So all these factors, either in combination or some of them, if you fail to meet the mark, it may contribute to GERD. Poor lower esophageal sphincter function, anatomical problems like hiatal hernia, issues with esophageal clearance, which helps to minimize contact time of the refluxate with the esophagus, your local mucosal resistance within the esophagus, gastric emptying when it is on point, it will reduce gastric pressure or abdominal pressure in general, and the nature of the refluxate itself. If it is too harsh, it can easily cause problems. Together with this, of course, we've mentioned all these aggressive factors. So the gastric acid, the pepsin that can digest proteins, obviously the lining is protein, bile acid and pancreatic enzymes like trypsin and chymotrypsin. When you have them in the refluxate in enough quantities, then that can be a problem. Of course, I mentioned that apart from the composition, the volume, if you have high amounts of the fluid being regurgitated, then the esophagus will have a huge task to clear it very fast to minimize contact time. If the volume is small, you may easily clear it, reduce contact time, and reduce damage. So the longer the contact time, to the higher possibility that there could be what? Damage. Any question? So it's not just one way cause. All in all, we say the most important factor is the lower esophageal sphincter pressure, but all of this may also contribute. All of this may also contribute. Because at times you realize that the lower esophageal sphincter tone is on point, yet the person will be suffering from GERD. So it means that apart from the lower esophageal sphincter, there are other contributory factors as these that can also give you GERD. Any question? Any question? Any question? Class captain, any question? Hello?
No, please.
Class captain, are you there?
Yes,
Okay.
please.
Please give me 1 minute. I'm coming. Just 1 minute. 1 minute. All right, so let's continue. So that is the pathophysiology, that is hiatal hernia. Now, how do these individuals present? The signs and symptoms. This depends on whether it will happen within the esophagus itself or in organs or areas outside the esophagus. If it's happening within the esophagus, the signs and symptoms are termed typical. If it happens outside the esophagus, but in areas like your pharynx, your larynx, your airways, your mouth, then we say that these signs and symptoms are atypical. So typical of GERD, if it happens within the esophagus, then the person will normally complain of heartburn. There could be hypersalivation, otherwise known as water brush. It may cause belching, and of course, you will feel the refluxes, regurgitation will come. This normally happens depending on your position, or it gets worse depending on your position. So if maybe you lie down flat, so in recumbent position, or you try to bend over, or during eating, when you load a lot of stuff in your stomach, especially fat-containing stuff, then it increases your abdominal pressure, it delays gastric emptying. Then the person may report of heartburn, water brush, the person will belch, and the regurgitation will come. In the atypical one, so normally also known as the extraesophageal type, it becomes very difficult because you realize that several other conditions, for example, if you are talking about cough coming from extraesophageal GERD, several other conditions can also lead to cough, asthma, COPD, infectious cough, and what have you. So in that case, it becomes very difficult to be able to diagnose. But note that GERD can also contribute to extraesophageal signs and symptoms like cough. Just that other conditions may also lead to that. If you have laryngeal inflammation, pharyngeal inflammation, it may or may not be due to GERD. But if it is due to GERD, then it is classified as part of the atypical symptoms. So you could have non-allergic asthma, chronic cough. It can even affect your voice, hoarseness of voice. Your pharynx could be inflamed. That can even result in chest pain, and repeated exposure of the acid, the bile secretions, and whatever to your teeth can cause dental erosion. These are what we refer to as the atypical symptoms of GERD. If the GERD is so extensive, then it can lead to severe damage and some alarming symptoms may occur. This, of course, includes when the normal squamous epithelium is replaced by the columnar epithelium, and this goes. If the acidity is so, and you have it, esophageal strictures. Getting Barrett esophagus, we said, is a high risk factor for esophageal adenocarcinoma, so esophageal cancers. If these serious problems occur, of course, continual pain will come, difficulty in swallowing, and then pain during swallowing, odynophagia. All of this may occur. With this, the person will not find it easy to eat, and therefore weight loss may occur. The person may feel like he's being choked. You have acid always coming in there. You feel like you are being choked. You can't breathe well with all these respiratory issues. When these occur, then we say that the person is having alarm signs and symptoms, and of course, proper attention must be taken. Any question? Any question? Okay, because GERD, normally people mistakenly take it as at times cardiac issues and vice versa. It is very important for us to know some differences between the issues with reflux pain and issues with cardiac pain during ischemia. So CAD pain and GERD pain. So normally, when the chest pain or the heart pain or heartburn is from the reflux, it is described as burning. And normally, it gets worse when you bend, because when you bend, you increase your abdominal pressure and more of the acid will be regurgitated. Or when you stoop or you lie down. So normally when you have some burning sensation in the chest, when it gets worse upon bending or lying down or whatever, then you will know that, oh, this has something to do with GERD, not ischemic. So ischemia, if you bend or you don't bend, it won't get better or it won't get worse. So it doesn't have anything in relation to this. The type of pain in ischemia will be described as gripping or crushing. Remember, this is burning. You know that in angina, they always say that the pain radiates. So it radiates to your left arm, your neck. Reflux pain doesn't radiate. It stays within the chest. It becomes worse when you drink hot drinks or at times alcohol, obviously. This is worsened by exercise. Angina is worsened by exercise, not by drinking hot drinks. For angina, if you rest or you take nitrate, the pain may go away. For reflux disease, you realize that when you take antacids or you take PPIs, then the pain will go away. If you go and take antacids or PPI during angina pain, it won't go. So if you take PPIs or antacids and then the pain resolves, then you know that you are heading towards GERD. Typical of cardiac ischemic pains, it normally comes with difficulty in breathing. So these are some few differences between reflux and cardiac ischemic pain. So when you're having chest pain and some of these things happen, at least it may give you a fair idea whether it is due to heart issue or esophageal issue. Any question? Any question? Okay. So then if you know the signs and symptoms, and we can even, through subjective data, differentiate pain or chest pain due to GERD from chest pain due to heart disease, let's try and then confirm it, because these are all subjectives. So it is important that, of course, you gather history. We just mentioned that certain food substances, even family issues, drug issues can all contribute. Social history, your alcohol intake, your smoking. So you take all those history and then make good use of them. So family history, social history, drug history, even medical history, everything. Then, of course, endoscopy, a gold standard. You have to visualize the esophagus and see if there are any damages there. Is there any inflammation? Is there any damage? Of course, endoscopy will help you. So esophageal endoscopy. At times, you realize that the person is always suffering from GERD, but you don't see much reflux coming there. So you may have to do continuous reflux monitoring, maybe at night times. So you put some probe there, the person will take it home, and then as and when the reflux rate comes in, it doesn't matter the time, daytime, nighttime, the probe will be recording the pH of the esophagus from time to time. And then when the person returns to the clinic, the person will also write all the time that he experienced the heartburn, the chest pain. So if, let's say, at 2 a.m. at night or early morning, there is pain, the person will write 2 a.m. 4 a.m. it came, 10 p.m. it came. Then when the probe is removed, the pH probe is removed, that probe will also tell us all the time that acid came into contact with the esophagus. Then we try and then relate what the probe is telling us versus what the patient is telling us. Then if the two tallies, then we can confirm that, oh, okay, there is what? Reflux that is coming and that is causing. So if it's not easy for you to do endoscopy to confirm. Let's say there is endoscopy negative, but the person is always complaining of GERD. You can do the ambulatory pH monitoring. And with this, the patient records the time that he feels the signs and symptoms of heartburn. Then the probe will also record all the time that the refluxate came in. And normally you realize that the two will tally, and that shows that it is still GERD. At times too, you do manometry. This is to assess the motility of the esophagus, and therefore areas that are found not to be active. Through surgery, you may reset it and leave only the areas that are active to help prevent GERD. So manometry may be used prior to surgery to resolve GERD issues. So let's go through them one by one briefly. So endoscopy, of course, is the preferred technique that you can use to assess the mucosa. Of course, that one you are seeing the images. If there are any inflammation, you see. If there are any Barrett esophagus, you see. Any other complications, strictures or what have you, you will see. So endoscopy is very, very important, just as we use it a lot in PUD. But there are other new things that they are doing nowadays. I don't know if they are now in Ghana. So they can even let a person swallow a pill that they have inserted a camera. So instead of passing the tube during the endoscopy, they rather let the person swallow a capsule or a pill that has a camera in there. So they call it pill cam SU. So as the pill or the capsule flows through the esophagus, it will be taking images, and the image will be recorded on a certain sensor that is placed on the chest, and then eventually the capsule will appear in your feces after taking the image or running through the GIT, then you clear it from your GIT. This is better because you are not passing any tube, more convenient than when the endoscopy is done. Endoscopy is too invasive, and at times, or in all cases, you may even have to be sedated. Even with that, you still struggle. So if you have the pure cam SU technique, that is better. It's the same as endoscopy, but more convenient. Then the ambulatory pH testing that I said, so you put the pH probe there, normally 5 centimeters above the LOS, well within the esophagus. So the pH probe will be taking the times that acid comes into contact with the esophagus. So you pass the probe through the nose. So it is passed through the nose into the esophagus, and it will be there. You take it home because it is ambulatory. Then you, the patient, also will be taking or telling us the times that you felt the chest pains or any other signs and symptoms of GERD. Then the machine too will be doing its own part. So when you report back to the hospital, we take your report and what the probe is also telling us. And in most cases, if the times that the probe recorded that acid was there tallies with almost the same time that you also said you felt the signs and symptoms, then we know that your chest pain is coming from GERD. This is when you have done endoscopy and there is nothing there. It is endoscopy negative. Yet you are still complaining of signs and symptoms of GERD. Then we have to do the ambulatory pH testing. Maybe it happens at night or the time that you are not in the hospital. So in the hospital, we do the endoscopy, you are not finding anything negative. We will do the ambulatory pH testing, and maybe it will help us to identify or confirm that it is still GERD. Recently, they've even come out with a combined effect of impedance and the pH probing. The good thing is that this combination is able to measure the acid from the stomach and the alkaline refluxate. So this is an improvement on what the endoscopy and the pH probing can do. Nowadays, they also have radiotelemetric capsules, which in this case, it is attached to the esophageal mucosa. Then it will be monitoring the esophagus. The good thing is that It can do even up to 48 hours monitoring, less invasive than endoscopy again. So that is also available. People also can do empiric trials. We said that the pain when you take PPIs or you take antacids. So at times, instead of doing all this endoscopy and what have you, we can also do an empiric trial, normally an 8 weeks trial of PPIs. And therefore, if you were having repeated signs and symptoms that make us suspect that it could be GERD, by now they are off, then we may implicate GERD as the main cause of the signs and symptoms that you have been complaining. Well, we said that the pain due to GERD respond to antacids or PPIs. Then the esophageal manometry, where we try to assess the motor function of the muscles of the esophagus. So you need to evaluate this to know whether peristalsis is active. If not, then during anti-reflux surgery, we can cut the areas that are not functioning and leave only the areas that can what? Contract and therefore move stuff upwards. Any endoscopy, pure chemistry, ambulatory pH testing, 8 weeks PPIs trial, and then the new ones, radio telemetric axis, and then combined impedance and pH probing, we could confirm GERD as the cause of our signs and symptoms, especially heartburns. Typical of Ghana, the 8 weeks trial we do, endoscopy we do. I'm not sure of the new advancement. The PureCam SU, even the ambulatory pH testing, and telemetric capsules. I'm not sure about that. Any question? Any question before we go to what the guidelines are actually saying? The American College of Gastroenterology, what are they saying? Any question? Vice Captain, any issues? Hello? Hello? All right.
Hello, sir.
Hello?
Hello, sir.
Yeah, hello?
Yes, sir, please, you can continue.
Okay. All right. So let's look at exactly the recommendations from some of the guidelines. So American College of Gastroenterology, as an example, they are saying that if you have typical GERD symptoms, heartburn, regurgitation that you are experiencing, but there are no alarming symptoms. There are no alarming symptoms. Excuse me. Please excuse me. Yes. Hey. Shh. Stop making noise. Hey, my team good. Hello? Hello?
Hello. Hi.
Okay.
Hi.
All right. So we can do the 8-week trial if you don't have any alarming symptoms. So odinophagia, dysphagia, those things are not there. Severe anemia is not there. Then of course you have the luxury to play around. You do the 8-week trial of the proton pump inhibitor and If the person responds, then you can confirm. So that is what the American College of Gastroenterology they are saying. Of course, PPIs are taken before meals. We established that last week. Then they're also saying that attempt to discontinue the PPI in patients whose classic GERD symptoms respond to an 8-week empiric trial. So that is what you intend to do. After 8 weeks, everything is gone. It means that the thing is healed. The patient is no more having problems. So what do? There is no need for you to continue. But perform endoscopy. Ideally, after PPIs, you stop the thing 2 to 3 weeks time, and the patient will get a rebound effect, or the person will not respond at all. If you do the PPI trial and the person doesn't respond, or if immediately after you withdraw the PPI, the signs and symptoms comes back, and of course, you have to go and do endoscopy and see, feel what is happening within the esophagus. So ideally, mild GERD, no alarming symptoms, PPI trial. If after 8 weeks, the person is not complaining of anything, you stop the PPI and the person will be okay. Remember, you'll be doing treatment. So if you go and do all those, engage yourself in those trigger factors, then it may bounce back. We are talking about when you are observing all the lifestyle modifications that we will tell you during counseling, and then so you are not going to get a rebound. But if after removing the PPI, you get a rebound effect, or say the person did not respond to the PPI trial at all, then of course you have to do the endoscopy to find out whether there are some problems there, esophagitis or what have you. Again, they are saying that in patients who have chest pain without heartburn and who have had adequate exclusion, you've done differential diagnosis and you have excluded that it is not a heart disease. So there is chest pain, there is no heartburn, and there is chest pain. You have also ruled out the fact that it is not heart disease. Then, of course, you have to go in and again do endoscopy, and at times you may even do the ambulatory monitoring as well. So there is chest pain, but the person is not saying that it is heartburn. Fine, you too, you've ruled out the presence of heart disease. Heart disease here, we are talking about CAD, like angina. Then you still have to go ahead and then look at what is actually there. You got chest pain, no angina, no MI, nothing. There is no heartburn, but there is chest pain all the time. Then it is only sensible for you to go in there and look at the esophagus and see whether there is something wrong. If you do that, you are not seeing anything, then maybe you don't have any damage there, but maybe at night or something that the patient is not around, the reflux comes in through regurgitation and it causes problems. So through the ambulatory pH test, you may identify. So you do this or that or both, which will be more effective. They are saying that do not try and do any barium assay. You are trying to find maybe some source within the esophagus. So you are taking barium, you are swallowing barium to coat there to try and find out any source. Don't do that. It's not necessary. You can do your normal endoscopy to identify problems or not. Again, endoscopy is recommended as the first test for the evaluation of patients who present with alarming symptoms like dysphagia and other alarming symptoms. And also patients who come with risk factors with Barrett esophagus. Of course, with this, you have to view the esophagus and see whether you are having columnar cells replacing squamous epithelium. Are you having bleeding ulcers there? What is there? So it's not surprising that in alarming symptom situations, they are recommending that you do endoscopy. Also, in patients for whom the diagnosis of GERD is suspected, but is not clear, and endoscopy shows no objective evidence, they recommend that you do the reflux monitoring. Of course, I've been talking about this. But reflux monitoring without PPIs alone is not a very good test, especially when the person comes with the Los Angeles grade C or D reflux disease. So if you do only reflux monitoring, that is the pH monitoring, without the person taking PPIs, especially during serious situations like Los Angeles grade C or D. We are going to look at the grading very soon. They are saying that they don't recommend. Or patients who have Barrett esophagus, reflux monitoring alone is not good. You need to see the thing. So pH monitoring and you recording to confirm whether it is GERD or not. That alone will not be enough. You have to do, in addition, endoscopy, because these are serious situations. You know Barrett, you have to visualize it. Los Angeles grade C and D normally the classification depicts the extent of damage. So through grade A to grade D, you realize that the extent of either inflammation or sores becomes larger. So for example, grade C, you have one or more mucosal breaks that is continuous and it's between the tops of two or more mucosal folds, but it doesn't cover more than 75% of the circumference of the esophagus. The last grade, there is high breaks and it is higher than 75% of the esophagus. So those who fall within these two categories, it means that you have extensive damage. And you testing for only pH to confirm that it is acid that is coming in to cause the problem is not enough. So that alone, reflux monitoring of therapy solely is not enough. You have to do additional stuff like endoscopy and maybe even add PPIs. You do a lot of things to be able to, as in, make sure that you have indeed confirmed the presence of the condition. Any other questions? So that is what the American College of Gastroenterology, they are telling us. If you don't have any alarming symptoms, you are free to do the 8-week trial of the PPIs. If there are alarming symptoms, you have to visualize. So endoscopy, you must do it. If you have not enough, you need to do other things to copy, and it is endoscopy is being reported. Then you have to do the ambulatory pH monitoring, where you insert through the nose a pH probe into the person's esophagus, approximately 5 centimeters above the sphincter, well within the esophagus. The person will take it home, and then as and when the signs and symptoms comes, the person will be recording the time. The person returns to the clinic, you take the probe, you check the times that the probe will also record the presence of acid. You compare it to what the patient is telling you that time A, B, and C, I felt chest pain or whatever. If it tallies, then you are now sure that it is GERD. Then you can treat. Any question? Any question? So we know the signs and symptoms, subjective. We have now confirmed the presence of GERD, objective. Now we are to treat. So let's try and treat. Every treatment, you need to set your goals of therapy. GERD, one of the main goals is to try and alleviate or eliminate the patient's signs and symptoms. Heartburn is painful, it's not convenient. You'll be belching and all those things. So we need to alleviate the patient's symptoms. Then decrease the frequency or recurrence. Every now and then you are having heartburn. We have to find a way to decrease it. And of course, the duration to which the refluxate comes into contact, it's almost related to the extent of damage. So all these, we will put in measures to minimize it. If there are any wounds or ulcers, we will try and then promote wound healing. If there is any injury, we will try and then solve that. And all the complications, bleeding with anemia, adenophagia, strictures, Barrett esophagus, adenocarcinoma, it should be part of our aim to prevent these complications from happening. And therefore, we will adopt these strategies. We adopt these strategies to try and then achieve our goals. So what are these strategies? We will try and decrease the acidity of the refluxate. But we said that the composition and the volume of the refluxate contribute to the pathophysiology. So if it comes in and is not that acidic, it may come, but it may not cause any harm. We will try and decrease the gastric volume available to be refluxed. So then we can help improve gastric emptying so that all the stuff doesn't stay in the stomach and then cause high volume of refluxate. Of course, that is gastric emptying. Then we try to increase the lower esophageal sphincter pressure so that it will be competent enough, close tight, and will not allow backflow of the fluid into the esophagus. And of course, should in case we fail to achieve this and still we have some amount of acid coming into contact with the esophagus, can we improve clearance so that we reduce contact time of the refluxate with the esophageal lining? Can we also cover the lining of the esophagus so that even if the acid comes in, it won't have direct contact with the esophagus, but rather it will have contact with the mucus, for example, or any other synthetic thing that can act just like mucus so that we protect the underlying tissue. We are going to adapt all these strategies in combination to help us manage GERD. Any issues? Any issues? Any issues? Of course, as always, it is good to observe non-pharmacological strategies first. If you are lucky, in most situations, the non-pharmacological interventions will be enough, and you may not need to call for reinforcement by using drugs. And therefore, per what we have discussed so far, can you predict or state any lifestyle modifications that can help us avoid GERD, or if it is there, that can help us manage GERD? My lady, I should know your name. You ask questions. What's your name? The lady who normally asks questions. I've forgotten your name. Can you please give us some lifestyle modifications per what we have discussed so far? The risk factors and what have you? What and what would you tell somebody with GERD to do without drugs, outside drugs? What lifestyle should the person adopt to help prevent or manage GERD? Anybody?
Okay, so I advise the patient not to eat very late at night, or even if they do, they shouldn't sleep immediately.
Your reason for this?
Okay, so eating very late at night or sleeping right after eating can predispose or increase the risk of having reflux, as we've discussed earlier. So
What did we
definitely it
say?
won't be advised.
I want you to
Pardon?
say it. I want you to say it. How? How would eating late at night contribute to
Okay, so eating, for example, when you eat fatty foods can relax the lower esophageal sphincter, that's predisposing the patient to by doing that have an increased risk of having reflux.
Okay. What else? All considerations possible, you can tell us. What else? Social history. Are you there? So what advice would you give to any person in relation to social history?
I think those. Okay.
The person should avoid smoking because of the
Smoking, alcohol, eating
like,
late. Okay. So all those things that we've discussed, drugs that can possibly cause GERD, food substances that can aggravate or cause GERD, all those things you must consider as part of the lifestyle modifications. Obviously, you can't tell somebody not to get pregnant. Procreation must go on. It's a risk that you can't avoid. But when you get pregnant, at least there are means that you can do to minimize that. We are saying that we are not going to give birth. No, GERD cannot prevent us from doing so. We know that when you get pregnant, it's a huge risk factor, but we will risk ourselves. It's worth it to get pregnant and suffer from GERD and get a nice bouncing baby than to say because of GERD you won't get pregnant. Yes, other non-pharmacological interventions include the type of surgeries that they do and several other endoscopic therapies that they do to treat the wound or to treat something like precancerous Barrett esophagus. They can even do gastric bypass. We are going to look at that in just a moment. So let's come to our own drug treatment. Remember, you do drug treatment to augment. Hello?
Hello.
You
Please,
do
I have a
drug
question.
Yeah, hello?
I have a question concerning the non-pharmacological management.
Okay.
So for people who taking a lot of alcohol, do you tell them to stop taking alcohol or they should reduce their alcohol intake?
So when it comes to alcohol, normally alcohol, unless the condition is liver related, you don't normally say they should stop. Unlike cigarette that in all situations you say stop smoking, cease smoking. In alcohol, you say that you reduce it. Then you give the person the allowable limit, the 14 units per week. Remember, the patient doesn't know 14 units. So you have to try and then explain that thing, convert it to volumes for the person. But if it's a liver condition, you know the effect of alcohol on the liver. That one is best for the patient to cease taking alcohol. All other conditions, the patients can take in moderation. What is moderate? 14 units. Spread evenly across the week. If you miss today's 2 units, for example, you can't add it to tomorrow's and take 4. 2 units per day. Are we okay? But if the person can stop, then that's the best. But you know, alcoholics is not easy. So you may allow them to take the amount that is allowed. But if the person can stop, then that will be better. Are you okay?
Okay.
All right. So our field, drugs. You don't take drugs and stop observing the lifestyle modifications. You use drugs to augment the effects of the lifestyle modifications. So let's see some of a brief pharmacology of some of the drugs that we can use to help in GERD. Some of them, they've been taken to relegation because of side effects, and though they have the potential to help, but because of numerous side effects, they are not employed in current management of GERD. So you can see agents that can improve esophageal clearance so that contact time is reduced. Acid. Hello.
Hi.
I went off something. Okay, I'm coming. Okay. All right. So where were we? We're on drugs. Where am I going? Oh. Hold on. I'm coming. Yes. Okay. Just a minute. Coming. Okay. So you can have these agents like arginic acid, sucralfate, that can work just like the mucus. So they form a raft, then cover the surface of the lining of the esophagus, so that even when the refluxate comes, it is these agents that will have direct contact. By so doing, they protect the underlying tissue. So you don't get direct contact of the esophageal mucosa with the refluxate. So arginic acid, sucralfate. Then remember, gastric emptying. So if you have reduced gastric emptying, you build up pressure within the esophagus, you have large volumes you build up pressure within the stomach, large volumes of refluxate within the stomach, and therefore you are in trouble. So metoclopramide, cisapride, of course, metoclopramide is still in use as a prokinetic agent. So with this, you can make good use of metoclopramide, but not cisapride. Then agents that can improve the lower esophageal sphincter. Here again, at least we have metoclopramide in there that is still in current use. So you take metoclopramide, you are improving LOX pressure, you are improving gastric emptying because it's a technical no. Then, of course, we said the composition of the refluxate. So we can make it less acidic so that even when it is regurgitated, we don't get much issues. So you can use antacids to work just like the bicarbonate that comes from the saliva and then the local esophageal tissue to neutralize the refluxate that will come in. You can do H2 receptor antagonists. We talked about these agents as well as PPIs last week. Their work is to reduce the acid secretion so that they will increase intragastric pH, make it less acidic so that it doesn't become too harsh to cause injury of the various classes. Mucosal agents in use, LOS pressure increasing agent, metoclopramide, gastric emptying, metoclopramide, a prokinetic agent, neutralizing the acid and decreasing acid secretion, so antacids, PPIs, H2 receptor antagonists. Esophageal clearance agent, we are not using them because of side effects. So now, let's look at what the guidelines is saying. But before that, we have baclofen. Baclofen, which is a GABA B agonist. It can also help reduce transient LOS relaxation. So remember we said when it comes to the LOS, normally within a brief period, it can relax and therefore At that time, if you are not lucky and there is any increased abdominal pressure, then the regurgitation can occur. Baclofen can help minimize the number of times that we have such transient LOS realizations. It therefore helps to decrease the number of after meals acid and non-acid refluxes. Non-acid, you remember the biliary secretions and the pancreatic secretions. So baclofen, through this prevention, it helps to reduce the after meals, both acid and the alkaline events. And of course, nocturnal reflux activities, it also helps to decrease, as well as belching episodes. When you take it in doses between 5 to 20 milligrams 8 hourly, then it may help to avert the symptoms of reflux disease. So at times it can also be added to PPIs. If, let's say, an individual is not doing well on PPIs alone, then you can add baclofen at this dose. But because of numerous side effects, hardly would you see clinicians prescribing baclofen for GERD. The mainstay will be PPIs, H receptor antagonists, metoclopramide, and what have you. But it has the potential. Now, when it comes to treatment, what are the guidelines saying? We just look at the diagnosis from this same guideline, American College of Gastroenterology. So what are they saying in GERD? What are they saying? And this is almost the same as what the other guidelines are saying, the European guidelines, the Asian guidelines, and what have you. So the guidelines, based on lifestyle modifications, this is what they are saying. They advise that those who are obese or overweight, they take some measures to reduce their weight. You remember, obesity and overweight will contribute to intra-abdominal pressure. So those who are overweight or obese, if you want to have relief from GERD, then you should take measures to reduce your weight, reduce your food intake, the number of times that you take your meals, you should reduce them. The weight, the amount, the heaviness, full bowl, reservoirs, stop taking them in excess. If you are almost going to bed, stop eating around that time. Some people, you have the meat in the fridge. Even when they are sleeping, they will wake up and go to the refrigerator and take some meat, fish, or chinchinga or something and eat. If you do that, then you're putting yourself at risk of suffering from GERD. So avoid meals within 2 to 3 hours. Bedtime, don't do that. If you are the type who smoke cigarette, please stay away. The Americans are saying stay away. Any food that can trigger GERD, if you can't stop, you have to take them in moderation. So all these spices, the garlic, the onion, the tomato, the chili pepper, you have to reduce their intake. Drugs that can trigger GERD, you have to switch if possible. And then they also advise that if you normally suffer from GERD at night, then your positioning counts. So you may have to elevate your bed. Maybe you sleep on 3 or 4 pillows so that your head is elevated. So through gravitational flow, then clearance of the reflux acid in case it comes. And that will also not be easy for regurgitation to occur because it will be fighting against gravity to not be easy. So they are recommending these lifestyle modifications. In terms of the drugs, what are they saying? In terms of the drugs, what are they saying? As always, PPIs are superior to H2 receptor antagonists, just as we discussed in ulcer. Here too, same. So PPIs are preferred when it comes to you trying to achieve healing or maintenance therapy in cases of erosive esophagitis. Between the two, always choose PPIs over H2 receptor antagonists. Of course, you take PPIs before meals. You take PPIs before meals. We discussed that when we were discussing about the kinetics or the pharmacology of PPIs. Then attempts should be made to stop PPIs or to switch to as and when needed therapy when you get the problem off. So you are taking PPIs maybe for say 8 weeks. You are not getting any further signs and symptoms. It's not necessary for you to continue on like every day. So in that case, if you are not getting symptoms anymore, they advise that you do the PPI on PRN as and when basis, whilst observing the lifestyle modifications. And that is true. It's sensible. The thing is off, it's not coming. So why are you still taking PPI? Remember, the PPIs too do have their own problems, increasing problems with possible infections and the headache, the GI problems of diarrhea, constipation, and what have you. So if the work is done, you have to stop taking them and take them only on PRN basis. GERD patients should discontinue PPIs when they are relieved from erosive esophagitis, even the so-called serious complications, Barrett esophagus, and those whose symptoms have been resolved with PPI therapy. I've said that. PPI should be administered in the lowest dose that is effective in controlling GERD. Of course, if 20 milligram can do the work, why take 40 milligram? The higher the dose, the higher the side effect. So if 10 can do the job, don't take 20. If 20 can do the job, don't take 40. Yes. So apart from taking the PPIs, people may tend to add other products, let's say baclofen. Or maybe unnecessarily, you may want to do nighttime H2 receptor antagonist. If it's not necessary to do, stay away from that. Unless maybe the individual needs it. At times too, the person may be on PPI but may not respond. Think about other measures, probably the surgery, because PPIs alone normally will be enough to do the trick. If you bring in the other things, antacids and those things, they don't add any additional benefits. At times, in certain situations, for example, Los Angeles grade C and D, it may be necessary for the person to do a lifelong PPI therapy. So in cases where the condition is very dangerous, for example, Los Angeles grade C and D, where you have extensive damage, the person may have to be on lifelong PPI therapy. If you don't want to be on lifelong PPI therapy, then you go for one-time solution. And like say, grade C or D, two options. Either the person is put on lifelong PPI therapy, or if the person can't do this, can't adhere, then you can discuss a one-time problem-solving issue like surgery, anti-reflux surgery. And if it's successful, the person wouldn't need to go through the lifelong PPI therapy. They say that baclofen is not recommended because it lacks enough evidence, objective evidence when it comes to GERD. So that's why you are not seeing baclofen. It has the potential, pharmacologically, yes, it's helping to minimize the relaxation, the transient minimization and what have you. But clinically, the evidence is lacking. So don't recommend baclofen as part of your treatment. When it comes to prokinetics like metoclopramide, this is the recommendation. So you don't need to do prokinetics like metoclopramide unless there is gastroparesis. So maybe individuals with diabetes that through the neuropathy may suffer from gastroparesis. You have peristalsis not being adequate, and therefore there is stasis, then you may do the prokinetics to enhance the movement. So the only time that the guidelines are saying we can add metoclopramide as an example of prokinetic agent is when there is gastroparesis. What about sucralfate, those that work just like the mucus? They are also saying that these agents, alginic acid, sucralfate, are also not recommended except during pregnancy. So in pregnancy, you may add it. Other than that, it's not necessary. So on-demand or intermittent PPI therapy for heartburn symptoms control is recommended in patients with non-erosive reflux disease, of course. So if you do the endoscopy, you are not seeing anything endoscopic negative. And from time to time, the person says that he or she suffers from GERD symptoms. Of course, this is an over-the-counter agent. So when they come, give it to them for them to have control of their problems. Any questions so far? Any questions?
Please, I have a
Yeah.
question.
Mhm.
Please, are you saying that only diabetic patients can have the gastroparesis?
That's an example. Are you okay?
Yes, please.
Yeah. So if you have gastroparesis from whatever reason, then I cited diabetes as one of the problems. Then, of course, once there is gastroparesis, it is recommended that you may add a prokinetic. It can come from several other causes, not only diabetes. All right. Okay. So let's look at, yeah, hello.
So please, what did you say you do for those who are not responding to the PPIs? I didn't hear you, please.
Yeah. So if somebody comes and the person is not responding to PPIs, they are saying that PPIs should be enough. Adding other medicines like antacids, H2 receptor antagonists, and sucralfate and what have you normally will not bring any additional benefits. So it's not necessary for you to add other medical therapies. In that case, non-PPI responders, or maybe surgeries to solve the situation. Don't waste your time adding sucralfate, prokinetics, H2 receptor antagonists, and what have you. They won't add any additional benefit. Are you okay?
Yes, sir. Thank you.
Right. Okay. Any other question?
Sir.
Yeah, hello.
So, my question is, can this GERD be reversed? Can it be corrected?
Oh, yeah. Yes. Even when you have Barrett esophagus, complications where the columna is replacing the squamous epithelium, when even it results in deep ulcers with bleeding, yes, it can be corrected. But it depends on both the treatment, as in the clinical team, and the patient in particular. Are you going to observe all the things that you are being advised to do? That is a key issue. But if you give you treatment and you go about doing what we advise you not to do, then of course you are going to suffer. Even peptic ulcer, you can reverse it, and then it will be off. It will heal. One of the goals of therapy was to what? Heal it, prevent recurrence and all those things. So yes, with adequate and appropriate management, both lifestyle and pharmacological, should there need be, is treatable. Are you okay?
Yeah, but it's easily it can resurface again.
Yes, that is if you are engaged in any of those things that we say don't do.
Okay.
All conditions are like that. Malaria, we say don't expose yourself to mosquito bite. We treat you today. You are healed. You are okay. Then you go and stand in a room where you have a lot of mosquitoes. You get it again. So prevention is key. All right. Okay, so let's look at pregnancy. let's look at pregnancy. So pregnancy, GERD is very common. 2 out of 3 pregnant women will always experience GERD. Of course, we said the pregnant hormones, estrogen, progesterone, their concentration shoots. They are maintaining the pregnancy, so they should be there. And of course, the bad thing is that when they are in high concentrations like that, they reduce the LOS pressure. They reduce gastric emptying. The developing fetus too will enlarge the uterus and increase intra-abdominal pressure. All these have been discussed during the pathophysiology, and therefore it's not surprising that you have to test 2 out of 3 pregnant women. If you have 3 pregnant women, at least 2 will complain of heart pain. So if it's common, then what do we do? Because they will get it. So the recommendations is that you observe the lifestyle modifications. You observe the lifestyle modifications. You are pregnant, don't smoke. You are pregnant, don't drink. You are pregnant, don't eat at night. Don't be taking fatty meals. All those risk factors, they should make sure that they avoid. You eat too much fatty meals at night. So you can start with this to try and then solve the issue. And if these fails, if the lifestyle modification fails, for pregnant women, they are allowed to take antacids, aluminum containing, calcium containing, magnesium containing. Remember, constipation with aluminum, rebound acid secretion with calcium, diarrhea with magnesium. The most common ones is preparations that do have a combination of magnesium and aluminum to cancel out their opposing effect. So constipation from aluminum will be cancelled by diarrhea. Then we get only the antacid effect. You can also use alginate or sucralfate to go and work just like the mucus to prevent direct contact. So these are normally first line, should in case lifestyle modification fails. And if these two doesn't work, then either H2 receptor antagonists or PPIs could be used. In terms of the recommendations as to whether a pregnant woman can take an H2 receptor antagonist / PPIs or not, the American FDA, they've grouped these 2 drugs, all of them, every drug that belongs to the H2 receptor antagonist or PPIs, except omeprazole under pregnancy category B. You will look at the category soon, so don't worry. So all PPIs except omeprazole, and then all H2 receptor antagonists category B. So it's good to go. They are okay in pregnancy. And omeprazole is category C. So that one normally the benefit outweigh the risk. So let's look at these categories. So this is applicable to all drugs during pregnancy. So if you look at the drug label and they say that this is FDA category A in terms of pregnancy, or B or C, then you know where you can place it and then know whether it is okay to use in pregnancy or not. So for pregnancy category A medicines, they are saying that, yes, that drug will be adequate when it comes to pregnancy. So we have adequate and well-controlled randomized controlled trials in pregnant women, which is not easy to do because in most clinical trials, pregnant women are excluded in most. But for a drug to be classified as category A, then it means that we have enough evidence by using pregnant women in a trial, and we don't have any risk of fetal abnormalities, then that drug will be classified as pregnancy category A. B, there is animal studies, pregnant animals. So you do experiments with pregnant animals, and it has revealed no evidence of harmful effect to the fetus of that animal. However, we don't have adequate tests or studies when it comes to human pregnancy. So human beings who are pregnant, we don't have any evidence. We haven't done any trial on them, but by using animal models, we know that, yes, they don't cause any harm. Or animal studies have been conducted and there are no adequate and well-controlled studies in pregnant women. In that case, you classify the drug under class B. Class C, so all PPIs, all H2 receptor antagonists, except omeprazole, they fall under class B. So no evidence of harm to fetus by using animal models. Then class C, animal studies have shown an adverse effect and there are no adequate and well-controlled studies. Class A, no evidence when it comes to animals. Class C, there is somewhat problems with animal studies, but we don't have evidence on pregnant women, or there are no animal studies that have been conducted, and you also don't have adequate or evidence when it comes to human who are pregnant. And these drugs will be classified under category C. D, studies, adequate, well-controlled trials in pregnant human beings have demonstrated some risks when it comes to the fetus. However, the benefit for using the drug outweighs the potential risk. So in that case, the clinical team will decide the benefit as against the risk ratio. Then they decide. Said drug will be classified under D. As for category X, is a no-go area. You have evidence enough to show that in both animals and human beings who are pregnant, there are problems with that drug. In that case, any drug that is flagged pregnancy category X is a no-go area. So most PPIs, except omeprazole and H2 receptor antagonists, they belong to class B and they are good to go. So should in case the lifestyle modification is not enough, you try any of the first line agents and still is not enough, you can switch to at least PPIs, H2 receptor antagonists, but you won't start with omeprazole. You are starting with rabiprazole or cimetidine. Any question? Any question? Okay, so let's look at the extra esophageal GERDs. So we've been talking about the typical ones treatment. So how about the ones that maybe is in the pharynx, in the larynx, the one that is in the airways, coughing, and it is still caused by GERD? So please switch off mute yourself. So of course, in that situations, you evaluate for non-GERD causes in the patient. Of course, you are having issues outside, not necessarily GERD. So you don't have to rule out anything. You need to look out for other factors that can also contribute to the problem. So evaluate for non-GERD causes of that symptoms in that patient. That normally happens in extraesophageal GERD before implicating GERD. It may not even be due to GERD. So do that. All possible tests must be what? Done. Don't just go straight away and say that, hey, there is this cough, there is pharyngeal inflammation and whatever. So straight away it is GERD. Look out for esophageal manifestations of GERD, cough, pharyngitis, and whatever. But who don't have the typical signs and symptoms of GERD should undergo the reflux testing for evaluation prior to PPI therapy. So you should do that. So the reflux testing should be done. You can do the pH probing, the ambulatory pH probing. In patients with esophageal GERD and extraesophageal GERD, you can do the PPI trial for 8 to 12 weeks and then see if it will work, or before you do the test. So if it works, then fine, you can confirm that, oh, Once the patient is having, let's say, cough or pharyngitis, and I've given PPIs as a trial and it has gone, then of course it was truly GERD. And once it's gone, then you are okay. Okay, so red box, upper endoscopy should not be used as the method to establish a diagnosis of GERD related to asthma. The thing is not in the esophagus. So what are you going? Why do you do endoscopy? No, we are looking at extraesophageal symptoms. So it's not necessary for you to be going to the esophagus. In any case, if you have any damage or any issue with the esophagus, then the person will also complain of typical symptoms. This time, the person is complaining of extraesophageal issues. So it's not important for you to go and be doing endoscopy. So that is that. In patients treated for extraesophageal reflux disease, surgical or endoscopic anti-reflux procedures are only recommended in patients with objective evidence of what? Reflux. So please don't do that. You don't do endoscopy in such individuals. It's not necessary. Now, what if you have refractory GERD? GERD that doesn't respond to most treatment, GERD that doesn't respond to lifestyle modifications with treatment. What do you try? Let's look at what the guidelines are saying. Optimization of PPI therapy is recommended as first step in management of refractory GERD. For all you know, you've not optimized the PPI therapy. You've not hit the maximum. If 10 milligram is not doing the trick, it doesn't mean that 20 milligram may not do. Have you hit the recommended maximum dose? If not, you have to go back and then do that as your first line. So optimization of PPI therapy is recommended. Of course, you have to do esophageal pH monitoring. The thing is not working. It's not working, especially if the person is on PPIs and it's still not working. Then what you do is you take off the PPI, then you do the probing and see the trend, when and how much of the acid that will come in. The diagnosis of GERD has not been established by a prior PPH monitoring study. So you do this when the diagnosis having been done before with what you are going to do. Because if you have done the pH monitoring already, then there is no sense in repeating it. If an endoscopy showing Barrett esophagus is there, you have to look at when the acid is coming in. And therefore, you take your PPIs around the time that the acid is coming so that the PPI will be at its peak to arrest the situation for you. In situations where you are having Los Angeles grade C and D, and of course, you have to find out the exact time, the pattern of the secretion, so that you take your time to meet that pattern squarely and solve the problem. You can also do the esophageal impedance. You remember we said the impedance, the combined impedance, is able to help identify causes from both alkaline and acidic reflux. So you can put the person on PPI. And since in addition to the acid reflux, the impedance can also pick on the alkaline effect. If it's able to pick on the alkaline effect, then you know that, oh, the problem is not only due to the acid one, because the PPI will be attacking the acid reflux. And if still the impedance is recording something, then it means that the problem, in addition to the acid, the alkaline refluxate is also coming in. Then you know how to address the issues squarely. Patients who have regurgitated as their primary PPI refractory symptom and who have had abnormal gastroesophageal reflux documented by objective testing, then there is no way out. You have to consider anti-reflux surgery or transoral incisionless fundoplication surgery. So it means that if you are on PPIs, then it doesn't work. Your condition is refractory to PPIs. Objectively, we have confirmed that yes, you are on PPIs, maximum dose, quality drugs, everything is not working. Remember, there is already a recommendation that there is no need for you to be adding other drugs, thinking that adding those drugs will help give additional benefits. It won't work. In this case, as I said already, surgery is the way out. So you do anti-reflux surgery or you do the transoral incisionless fundoplication. So once you have fundos here, it means that they are going to work around the fundos of the stomach. But this is incisionless. They don't cut. But anti-reflux surgery, they will have to cut. So that one, the surgeons, they are better when it comes to this. So they will have a better explanation as to the procedure that they do. But note that if you fail on PPIs, the next option is surgery. Whether they will cut you or they won't cut you, then you have to do surgery. So what are the options? What are the options? So anti-reflux surgery will come in, as we have said, when there is objective evidence of GERD, very severe ones, or you have failed on PPIs, or if you have large hiatal hernia. So herniation, to solve it, it is surgery. You can't use drugs to solve hernia. So if hiatal hernia, if objectively you are having excessive reflux and causing a lot of damage, anti-reflux surgery may come in. Then persistent troublesome symptoms, even on PPIs, you have to go for reflux surgery to solve it. These are not the cases where you'll be using medicines. It won't work. It won't work. Then you can also, the transoral incisionless fundoplication is another option. In terms of complications, this is lesser than when you do the anti-reflux surgery. So if maybe it depends on the capabilities of your team, your surgical team. If they can't do this, then the easy way out is this. But this is associated with more complications. Anti-reflux surgery is associated with more complications as compared to the incisionless procedure. Then at times they can also use heat through radio frequency energy to try and then maybe kill tissues like the columnar cells that are found within the esophagus. But that is not recommended as an alternative to medical or surgical therapies due to currently limited data. So it is something that they are still working on, the radio frequency energy. So it is the use of heat to do this treatment as to clear columnar cells that has replaced squamous epithelium cells. At times too, they can use magnetic sphincter augmentation. So the sphincter that is loose, the lower esophageal sphincter that is not contracting and it is open, they can use some magnet at times to wrap around. So it's like they are tying the sphincter so that it will be closed, not wide open, to allow the stomach content to pass through. So they can also apply magnetic sphincter augmentation, a form of tying, just like you are using a rubber band to tie some tube, the opening of some tube. And this is done through laparoscopy. So it's another surgical intervention. By so doing, the sphincter will close and it will not open. You can also do the Roux-en-Y gastric bypass surgery. This surgery, I'll show you the picture very soon. When you do it, it's like you are trying to reduce the size of the stomach. You cut a certain portion of the stomach and then you create a smaller stomach. Then you bypass everything and connect it straight to the small intestines. By so doing, now that you have reduced the size of your stomach, it means it can't contain a lot of food. So you eat very small amount of meal and you are full. With time, you realize that if you are obese, then you'll be having weight loss. So this is a typical picture. So you can see that this is the huge stomach from here to here. So they've cut off some aspect of the fundus. And now this will be your stomach henceforth. So all these areas are useless now. You don't have this huge stomach that will accommodate huge amount of food. You eat and eat and eat, and you are always growing huge. No, you've created a smaller pouch, a smaller stomach here. So you eat very small, you are okay, then you will bypass it to join the small intestines. So with this, you realize that you are going to eat small. So with time, you lose weight. You don't eat too much for you to have increased intra-abdominal pressure to put pressure on the sphincter to go. And since they've connected, the moment you eat, it just go through. There are no blockades and what have you. So this is another strategy, but the good thing is that it can also help solve obesity or overweight for you. So these are the surgical interventions. You have your anti-reflux surgery, your incisionless fundoplication, then the use of heat to try and then tying the sphincter with some magnetic bands, and then the bypass surgery. These are also available should in case your PPI therapy fails, if the girl is refractory to PPI therapy. Any questions? Of course, I understand we should focus on the medicines, but note that these options are also available. Non-pharmacological therapy, should in case you fail, note that it's not only about drugs. You can also do other interventions to solve the problem. But we are more interested and we are happy when drugs are included, because that is where we can get hugely involved and then make our interventions. Any questions? Any questions? Class captain, any issues? Because if there are no questions, we are done for today's meeting. Class captain, any questions, any announcements? Hello?
No,
Class?
please. No, please.
All right. Okay. So then I will send the slides to you, first to the class captain and to you. We meet same time next week. I'll look at the topics and then give you prior notice as to what we are going to do so that you read ahead. Okay. So have a nice day. Good morning.
Bye.
You too.
You too.
Bye.